So good evening friends, Dr. Rajamahendran here, your surgery faculty in DocTutorials. So today we are going to have an interesting clinical Thursday topic, that is on Phaeochromocytoma. A 20 years male, 20 years male, a psychiatric patient on medical treatment. Good evening friends, Dr. Rajamahendran here, your surgery faculty in DocTutorials. So psychiatric patient on medical treatment presented to you with the complaints of headache, palpitations, sweating, but this is not continuously seen, it is intermittent, it is an intermittent problem. So it is an intermittent issue, it is not seen all the time. So the classical history, this history is enough to make a diagnosis, like that is an interesting history. So welcome Vikash, welcome. So there are three important findings in the history. Patient is having severe headache, palpitation, sweating. There are three features, headache, palpitation and sweating. So this is what we call it as Phaeochromocytoma triad, which is seen in 90% of the patients. So 90% patients will have this triad. What is the triad? That is P, P, P. 3P is a triad of Phaeochromocytoma. What are they? Pain in the head, that is headache. So palpitations, and number 3, perspiration, nothing but sweating. So this is 3P. Usually this 3P is given in the history as headache, palpitation and sweating. So a patient is coming to you with the headache, palpitation and sweating. So good evening all friends. This is a short session around 30 to 45 minutes. So just we are going to approach one patient of Phaeochromocytoma. It's an interesting case history. See, this is a very young male presenting to you with a psychiatry patient, presenting to you with the complaints of headache, palpitation and sweating, but it is not continuous, it is intermittent. Please remember, this intermittent is what we call it as a term known as paroxysms. We call this terminology as paroxysmal, means intermittent. Paroxysmal headache, palpitation and sweating is seen in this patient. So this is aggravated by this headache, palpitation, sweating is aggravated by exercises, drugs, any general anesthesia and micturition. Usually this is aggravated by drugs, general anesthesia. So can you tell me some drugs which will aggravate Phaeochromocytoma? What are the drugs which will aggravate Phaeochromocytoma? This patient is on an antipsychotic drug that has aggravated his Phaeochromocytoma features. What is the drug? Can you tell me? That is a classical catch point. So the patient went to psychiatrist, he has given some drug known as tricyclic antidepressants. Very important. Tricyclic antidepressants. So the three drugs given from Bailey and Lowe, you follow the three drugs: tricyclic antidepressants, metoclopramide, Perinom is nothing but Perinom, which is used for antiemetic drug, metoclopramide and opioids like tramadol, Fortwin, all those things. These three drugs can stimulate the Phaeochromocytoma triad. It is intermittently seen. And now I am going to examine the patient. He is a 20 years male. Otherwise, when he is sitting in your cabin, he is absolutely normal. When you are seeing him, he is having no headache, no palpitation, no sweating. He is absolutely normal. From the history, you found out he is on tricyclic antidepressant. Some drugs he is taking from psychiatrist. So now you are asking your staff nurse to measure the BP. So measurement of the BP is extensively high. So please remember, the most common sign in Phaeochromocytoma is hypertension, which is seen in around 90% of the patients might have hypertension. But this hypertension is not always seen. Please remember, hypertension is again intermittent. Hypertension is also paroxysmal intermittent. So on examination of this patient, we have seen a BP of 200 by 140 millimeters mercury. So this is a hypertension seen, but otherwise patient is not having the typical triad. On examination, I could note here hypertension. So now on a detailed history taking, he is telling his father died of some thyroid disease, thyroid tumor. So thyroid tumor. His grandfather died of some kidney tumor. So some history is telling, positive histories. So father died of some thyroid cancer. His grandfather died of some kidney tumor. Now tell me what syndrome you should suspect in this young male. So this is understanding the basic point about Phaeochromocytoma. Phaeochromocytoma is such an high yielding aspect topic both for final MBBS students as well as for NEET PG aspirants. So logically understand this topic and read. Phaeochromocytoma is of two types. One is sporadic and another is familial. So familial cases are around 10%. So familial cases means what are the reasons of familial phaeochromocytoma? Men, very good, Saisudha Reddy, that is correct. Men 2A syndromes. Classically, men 2A syndromes will have phaeochromocytoma. Men 2A syndrome has 100% medullary cancer thyroid and 40 to 60% they are associated with phaeochromocytoma. So that is why I am telling this old man, his grandfather died of phaeochromocytoma probably. His father died of medullary cancer thyroid probably. So that is a classical clue point. So that is suggestive of men 2 syndromes. Number 2, what are other syndromes? Neurofibroma 1. So please remember what are the other syndromes associated with phaeochromocytoma. Bailey clearly gives detailed explanation of all the diseases. So VHL, von Hippel-Lindau disease. So these are the 3 familial causes: men 2A syndrome, 2B syndrome, neurofibromatosis 1 and von Hippel-Lindau disease. These 3 syndromes you should not forget. So men 2 syndrome, NF1, VHL disease. These 3 syndromes should be remembered for your exam. So this patient might be a case of final diagnosis. In this case is my diagnosis is a familial case of phaeochromocytoma, probably because familial cases are seen in young age, sporadic cases are seen in old age. Please don't forget this point. So what are the classical differences between these two? Sporadic cases are seen in the age of equal in male and female, and it is seen in above 50 years. Whereas familial cases are very common in young age. So very common in young age. Therefore, this patient is a 20 years male, young age patient, so has come to you with the familial phaeochromocytoma. So please don't forget this classical interesting point for your exams. This is a high yield MCQ topic for your exams. So what are the syndromes associated with the phaeochromocytoma? Men 2 syndrome, NF1, VHL disease. So this is very common in young age. Now, patient is sitting in front of your clinic. Please understand, read logically. A patient has come to you with the 3 symptoms, classical 3 symptoms of PPP, pain, palpitation, perspiration. Psychiatry patient is coming to you with the intermittent episodes, not always seen. It is an intermittent episode of headache, palpitation, sweating, which is aggravated by doing some exercises, taking some drugs. Since he is an antipsychotic, he is on antipsychotic drugs, probably he is taking some antidepressants like tricyclic antidepressants, which is aggravating his phaeochromocytoma. On examination, you should never forget the most common sign on examination is hypertension, which is seen in 90% of the patients. Please don't forget this point. So, and family history of father and grandfather died of thyroid cancer and kidney cancer. So, I am going in more favor of men 2A, men 2B syndromes. So, this is a classical flowchart essential for your exams. How are you going to approach this? How are you going to approach this patient now? So, now the first investigation I should do for this patient is what? Now, I have put a box. Please fill the box. These are repeat MCQs. How are you going to approach this patient? What is the first investigation you should do? Yes. So, a patient you are now suspecting maybe a phaeochromocytoma. So, you all know phaeochromocytoma is a neuroendocrine tumor. So, it is a neuroendocrine tumor arising from adrenal medulla. So, pathology behind phaeochromocytoma is a tumor arising from the adrenal medulla. This is adrenal gland. From the adrenal medulla, the tumor arising is known as phaeochromocytoma. Please understand. So, since it is a neuroendocrine tumor, it will secrete adrenaline, noradrenaline, dopamine, all the catecholamines will be secreted by this. Now, what should be the screening investigation? Classical MCQ, please don't forget, the screening investigation is plasma metanephrines. So, plasma metanephrines is the screening investigation which should be used. So, please don't forget plasma metanephrines. This is the first done investigation. There is a classical protocol from Sabiston. Please remember, it is first done investigation is plasma metanephrines. So, this is a metanephrine. What is metanephrine? It is a metabolite from the catecholamines. It's a metabolite from the catecholamines which is done by catecholamine O-methyl transferase. So, the epinephrine is converted to metanephrine by O-methyl transferase enzyme. So, therefore, the first important thing is O-methyl transferase enzyme produces more of plasma metanephrine. So, plasma metanephrine is elevated. See, very important point. This first step itself will exclude phaeochromocytoma. If plasma metanephrin is normal, it excludes phaeochromocytoma. Problem solved. Plasma metanephrin is normal means it excludes phaeochromocytoma, but there are many false positive cases. False positive is there. Therefore, so once plasma metanephrin is elevated, we have to go for the investigation of choice to diagnose. Please remember, what is the first done investigation? First done investigation is plasma metanephrin. It is secreted from the adrenal tumor, but it can have false positive because due to many drugs, due to various other reasons, plasma metanephrin may be high. Therefore, I should confirm it. How will you confirm it? So, confirmatory test is done by 24 hours. This is a repeat MCQ. Yes, anybody? Very good, Simran Shafi, that is correct. But VMA is the second confirmatory test. 24 hours urinary. What is the best answer? Urinary metanephrines. Urinary metanephrines is 95% sensitive. Vinyl mandelic acid is only 90% sensitive. So, which is better means metanephrines is better. So, 24 hours urinary metanephrines 95% is the best answer if it is asked in the exam. VMA is also correct, but it is second best. So, 24 hours urinary metanephrines is 95%. Please don't forget this. So, now if it is positive, I am confirming it is phaeochromocytoma. See, please remember, now I am confirming 24 hours VMA is increased. So, it is a case of phaeochromocytoma. Negative means what will I do? Plasma metanephrines increased, but urinary metanephrines are decreased. What should I do? Again, redo 24 hours urinary metanephrine and VMA. Very important point. Repeat it. So, repeat it one more time and see. Another time we have to, if negative plasma metanephrine means it excludes phaeochromocytoma. No further testing needed. So, if negative for plasma metanephrines, it is not phaeochromocytoma at all. There is no false negative in a plasma metanephrine. Plasma metanephrine will be definitely elevated. So, if it is elevated, it can be false positive. There is no false negative. So, therefore, it excludes. So, it is not a case of phaeochromocytoma. Discharge him. But if it is positive, go for 24 hours urinary VMA or metanephrine. That is confirmatory. That is one time negative. Don't confirm it yet. Go for another test. So, if it is another test which is equivocal, I have to now rule out. If it is negative, that is excludes phaeochromocytoma. Please remember. 2 times it is negative, excludes phaeochromocytoma. But if it is an equivocal value, 24 hours urinary VMA is equivocal. What should I do? I should do oral 0.3 milligram clonidine. So, clonidine will suppress the normetanephrine. Okay, it's a suppression of clonidine suppression test of normetanephrine. It is normal. Patient is not having phaeochromocytoma. So, normally secreting adrenaline will be suppressed. If it is a phaeochromocytoma, it is not suppressed. So, phaeochromocytoma, it is not suppressed. Clonidine suppression test is not suppressing the adrenaline metanephrine value. That is a classical MCQ point. So, please understand. I hope you are understanding the protocol in the investigations of phaeochromocytoma. The first investigation when a patient comes to you is to do, when a patient comes to you with the 3P, pain, perspiration, palpitation, immediately ask the patient to do plasma metanephrines. It is negative, no phaeochromocytoma. If it is positive, do 24 hours urinary metanephrine. Again, negative, do 24 hours urinary metanephrine second time. If it is equivocal, go for clonidine suppression test. Please don't forget, clonidine suppression test is used. Normally secreting metanephrines will be suppressed. Adrenaline will be suppressed. Suppression of normetanephrine. So, suppression of normetanephrine is seen, it is normal. If it is not suppressed, you are now entering into the confirmation. Now, your patient is now confirmed as phaeochromocytoma. What are you going to do? Now, I should know where is the phaeochromocytoma. Here is an important point because I told you phaeochromocytoma arises from, most commonly from adrenal medulla. Most common origin is from adrenal medulla. But phaeochromocytoma can be extraadrenal in 10% cases. So phaeochromocytoma is known as 10% tumor because many places I will be using 10%. It is 10% familial, it is 10% extraadrenal. What is the most common extraadrenal region? It will be arising from the sympathetic chain. Please understand. Phaeochromocytoma will arise from the sympathetic chain. Therefore, most common extraadrenal is para-aortic. See, please remember, it can be in para-aortic, it can be in mediastinum, anywhere it can happen. Mediastinum, it can be even in bladder, it can be in head and neck. So, wherever you have sympathetic chain, phaeochromocytoma can be extraadrenal. 10% time it is extraadrenal, but in that most common is para-aortic is the most common. And please remember, it is 10%. There are so many 10%, but I'll tell you last. Theory we will discuss last. Let us understand the clinical aspects. Okay, yes, organ of Zucker candle is the place where it arises in the para-aortic region and all. So please remember localization studies. The localization studies. Now, the investigation of choice to localize the phaeochromocytoma. What is the answer? My questions, please understand, these are all simple questions, especially for FMGE exam. These are all direct one-liners. So, investigation of choice to localize phaeochromocytoma. Answer is MRI. MRI is better than CECT because CECT IV contrast is very complicated. IV contrast can aggravate the phaeochromocytoma. Therefore, CECT is little not advised. So, better answer is MRI. See, don't get confused with MIBG and all. Please follow the protocol. Just go step by step what I am asking. So, investigation of choice to localize phaeochromocytoma. Answer is MRI. So, what is the answer is MRI. Please see the image of phaeochromocytoma. You are seeing a phaeochromocytoma here. So, the phaeochromocytoma here shows the classical image of. This image is a classical phaeochromocytoma image. Please don't forget this image. It's a classical phaeochromocytoma you are seeing here. So please understand, this phaeochromocytoma will have one appearance. What is the name of that appearance? This is having a Swiss cheese appearance. So classical appearance of phaeochromocytoma is Swiss cheese appearance in MRI. So MRI shows, this is a radiology MCQ. Swiss cheese pattern, that is the investigation of choice. So phaeochromocytoma has Swiss cheese appearance. CECT can show you one interesting finding, that is necrotic center part. Necrotic center is a classical feature on CT scan. See, but CT scan is not always advised. Please understand, CT scan is not always advised. This is a CT scan showing you a classical necrotic phaeochromocytoma. Can you see the arrow shows the left side phaeochromocytoma here? This is a typical phaeochromocytoma on the left side, classically having a necrotic tissue. Okay, necrotic tissue. So CT scan shows central necrosis, MRI shows typical appearance of Swiss cheese pattern. So don't directly jump into MIBG scan because it comes as a third. When there is a multifocal disease, or you are suspecting malignant disease or metastatic disease. So metastatic disease, then only comes iodine 131 or iodine 123 used MIBG scan. Meta-iodobenzyl guanidine. It is not the investigation of choice to localize a normal phaeochromocytoma. Please remember, investigation of choice to localize even ectopic phaeochromocytoma. Answer is what? That is also MRI only. Investigation of choice to locate ectopic phaeochromocytoma, it is in the para-aortic region. That is also MRI. That also is picked up very well by MRI. So don't jump into iodine 123 MIBG. Iodine 123 MIBG, where is it used? There are 10% of the tumors which are multifocal, 10% of the tumors which are malignant, 10% of the patient comes to you with a metastasis. Only those patients I will go for MIBG scan, meta-iodobenzyl guanidine. So please remember, I am telling you rule of 10 here and there. So therefore, in such cases only I will go for MIBG scan. And recently MIBG scan is replaced by new investigations 18F DOPA and 68 gallium DOTA-TET. See, please remember, these are scans based on octreotide based scans. Based scans in the sense this is based on the somatostatin receptor. So the tumors have somatostatin receptor. Based on that receptors, we have most sensitive investigation known as DOPA or DOTA-TET. These are recent updates in the investigation to find out this is also where only for multifocal malignant, those cases only we decide this. Okay, only for those cases we use 18F and 16.8 gallium DOTA-TET is a newly used investigation. Okay, the Bailey shows very interesting line. Only one line Bailey is saying. More recently, 18 fluorodopa has shown promise, particularly in the symptom in the setting of this phaeochromocytoma, where conventional imaging and MIBG are negative. So Bailey is not saying directly to use this. Only Sebastian is saying this. When everything else is negative, we should go on the latest update. Please don't forget DOTA-TET or DOPA. It is based on the somatostatin receptor. So now we have come to a conclusion. This is a case of phaeochromocytoma. Immediately the moment you confirm is a case of phaeochromocytoma, it is a must. I should start on some drugs. So now I should prepare the patient for surgery. Surgery is a gold standard treatment, but perioperative care. So like in thyrotoxicosis patients, we have preoperative preparation. Same way, phaeochromocytoma cannot be touched directly. If you go and touch, that surgical stress itself will kill the patient due to hypertensive crisis. Therefore, I should start the patient on alpha blocker. What is the drug of choice used in alpha blocker? Can you tell me what is the drug of choice? Yes, what is the drug of choice in alpha blocker? Phenoxybenzamine. So prazosin, terazosin, everything can be used, but they found out phenoxybenzamine is the better drug of all the drugs. So they are still using phenoxybenzamine. So initially they started with 10 mg BD, and this drug is increased to 40 mg 3 times a day. Like this we can increase the drug. From 10 mg BD to 40 mg TDS, the drug is slowly increased. It is increased in such a way there should be complete blockade, complete alpha blockade. Adequate alpha blockade is indicated by patient tells symptom number 1 and 2. What are the two symptoms? Yes, oral phenoxybenzamine we are giving, very good. So on giving this phenoxybenzamine, the patient has developed adequate alpha blocker is given by two symptoms. Number 1, postural hypotension. The drug should be increased gradually to 40 milligrams TDS until the patient develops postural hypotension and nasal congestion. He should develop nasal congestion and postural hypotension. When he develops postural hypotension and nasal congestion, we can now start beta blocker. Please understand this point. So don't start beta blocker before this symptom happens. So after complete alpha blockage only, we should start beta blocker. This is a very famous pharmacology question. All of you might be remembering that question. For persistent tachycardia patients who are having predominant epinephrine secreting tumors might have tachycardia. But this drug should be given only after complete alpha blockage, because if I give beta blocker without complete alpha blockage, the patients may develop hypertension crisis. This is a classical pharmacology concept. So you should understand, if I give beta blockers without alpha blockage, patients may develop hypertensive crisis can develop. So the unopposed alpha blocker will result in rebound hypertension. So please understand, carry home point, alpha blocker should be that drug that should be started immediately and give it until the patient develops nasal congestion or postural hypotension. After complete alpha blockade, you should go for beta blockers. Sir, if in spite of giving so much of alpha blocker, I am unable to control the PP, what drug can I add up? So there is a place you can add up. Calcium channel blockers can be added. So therefore, there are three groups of drugs given: alpha blocker, beta blocker, calcium channel blocker. All these three should be given, and patient should be made the adequate preparation. If you don't do inadequate preparation and if you take him for surgery, patient will die on table due to hypertensive crisis. So inadequate preparation can cause hypertensive crisis and patient may die on the table. So before doing this preparation, once upon a time people are doing surgery, 40% of the patients died. So now the mortality is now, after this adequate preparation, if I am taking the surgical mortality has decreased from 40%, it has decreased to 2% only. From 40% mortality of phaeochromocytoma, now it has gone to 2%. So please understand these concepts. This is a classical picture of F18F DOPA and MIBG. You can see multiple mets. Wherever you can see there is a liver mets here, there are multiple mets. So these are all points you should not forget. So for metastasis only we use this type of radionucleotide scanning. Otherwise we don't use radionucleotide scan. So this is a picture showing you classical phaeochromocytoma arising from the adrenal gland. Okay, we are going to discuss what is the management now. So patient has confirmed phaeochromocytoma. So let me recall, patient came to you with a triad of 3P. Triad of 3P: pain, perspiration and palpitation. On examination he had pressure. Pressure means BP was there. So history taking, history of MEN 2A syndrome. MEN 2B syndrome is present on history taking. So and we evaluated him. He is found to be a familial case of phaeochromocytoma. Familial phaeochromocytoma. Finally he was a familial phaeochromocytoma. And now we did the first done investigation, plasma metanephrines, and investigation of choice 24 hours urinary, not VMA, metanephrines, then only VMA. Okay, and after doing that, confirming that if there is a doubt, we did a clonidine suppression test if there is a doubtful cases. Not for all cases, clonidine suppression done for doubtful cases. And to localize the investigation of choices, MRI showing you Swiss cheese patient pattern. So metastasis is diagnosed with the help of iodine 123 is now replaced with 18F DOPA, which is further replaced by gallium dotatate, is better than iodine 123 MIBG scan. So this is a classical ending of the case history discussion. Now how are you going to treat this? By giving alpha blocker, calcium channel blockers, finally beta blockers. So these 3 blockers are given for this patient and the patient is now shifted to OT. What is a gold standard operation? So gold standard surgery is, what is a gold standard surgery for the patient? Can you tell me? So please remember, it is laparoscopic adrenalectomy is the gold standard. Why laparoscopy is best? Because there will be minimum handling. So when you are going to do laparoscopically, we are not going to handle the tissues roughly. We are going to handle minimal handling. So therefore, the release of hormones intraoperatively will be less. So laparoscopic adrenalectomy is done, and we have to use short-acting GA drugs. So anesthesia, there is a question. So short-acting drugs like enflurane is used during operation. So don't use long-acting drugs, only short-acting drugs are used. So this is a classical point, you should not forget. Very good. So that's a laparoscopic surgery, not open surgery, okay? But sometimes we need to go for open adrenalectomy indications. So sometimes you have to go for open adrenalectomy. Causes, what are the causes of indications of open adrenalectomy? Means if the size of the tumor from Bailey is more than 10 centimeters, Sabiston says 6 centimeter, but Bailey says more than 10 centimeter tumor, okay, more than 10 centimeter tumor. In MEN 2A, 2B syndromes, there may be multifocal tumors. So better to go for open surgery in such cases. So when there is a suspected MEN 2A, MEN 2B syndromes, better to go for open surgery. Number 3, signs of malignancy is present. Signs of malignancy. When will you say a phaeochromocytoma is malignant? Only when there is mets, when there is vascular invasion present. So when there is a vascular invasion present, or there is a organ involvement, adjacent organ is infiltrated. Such cases of signs of malignancy, you should go for a open surgery. Okay, so open adrenalectomy is done for more than 10 centimeter, meant to A, meant to B, signs of malignancy, and extraadrenal tumors. Extraadrenal phaeochromocytomas, we go for open surgery, not open adrenalectomy, open surgery instead of laparoscopy. So these are the indications of open surgery for phaeochromocytoma. So this is a classical topic, phaeochromocytoma. Even after surgery, Bailey says we have to keep them under follow-up because most of the patients can develop hypertension, recurrence, etc., etc. So we have to keep them on close follow-up 24 hours. In 24 hours, they can develop many complications like hypoglycemia, hypovolemia, and because we have removed the adrenal gland, they can even go for hypotension. So hypotension, all these things can happen in 24 hours. Keep them on close follow-up. Okay, keep them on close follow-up. This is a very important topic, clinical Thursday of phaeochromocytoma. If you have any doubts, please post me because this is a classical topic. It's an essay question for final years. It is a high yield topic for FMGE exam, and it is a must know topic for INICET and NEET PG. So I hope this will cover most of the graduates. So I thought of discussing this topic as a clinical Thursday topic for me. This is the first clinical Thursday topic in DocTutorials. So though I am doing many clinical sessions in my YouTube channel, but please follow me on my Telegram channel, Surgery Sixer, or in my Instagram. You can follow me on the page Surgery Sixer in Instagram. So these are the two pages you can follow for more updates and more questions. Okay, so any doubts, if you have related to phaeochromocytoma, you post here. And what is this 10% means? I already told you 10% is a 10% tumor. People call it funny way as a 10% tumor because it is 10% seen in children, it is 10% familial. So it is a funny question. 10% metastasis, 10% ectopic, like that, whatever you want, you can put 10%. 10% is familial, 10% metastasis, 10% ectopic, 10% multifocal. So like that it goes on. 10%. Therefore it is known as 10%. Okay. Therefore it is known as 10%. You can download this PDF in this Telegram channel. Okay. You can download in Telegram channel. In this channel you can download the PDF. So Surgery Sixer is my Telegram channel name. You can download that. I will also share it with the DocTutorials. You can also download from DocTutorials. Yes. So no doubts. Shall we complete? Yes, 10%. There are so many 10%. Telling you, whatever you want 10% you can put. 10% bilateral. So whatever you want 10% you can put. 10% will come for many 10% is there. So around 10% are there. But it is all funny questions. They are not so important. So what is important in PG entrance exams as well as for practices to understand the basics of the disease. So you understood the basics of the disease, patient comes to you with a paroxysmal episode. A case of phaeochromocytoma will be living one among you. He will suddenly have headache. He will be telling, sir, I am getting on and off headache, palpitations. You might not be finding the diagnosis. You might be missing the diagnosis, and once you are thorough with this concept, one day in your practice, a patient coming to you, hypertension patient with a palpitation, sweating, you will think of phaeochromocytoma. So first important thing in clinical practice is think of this is possible. Think this is possible, this is possible. So when you think it is possible, then only you will know how to evaluate. So this question, this topic will make you, I will be very happy in future if you are going to diagnose one phaeochromocytoma patient based on this concept. Okay. Thank you all friends. Clinical Thursday clinical sessions will be done. So every Thursday in DocTutorials there is a clinical session. Right, try to attend it. Okay. Thank you all. Thank you friends. Bye.